Thanks, Sadia, for the introduction. Hello, everyone. It's a pleasure to be here today. And me and Gail, we are very excited to present on our recent publication entitled Engaging Women with Lived Experience in Tailoring Educational Resources for Cardiovascular Rehab. This is just one, let's say, one publication of our, I don't know, like how many years are we have been working together, Gail? Maybe 4 years. So, but this is a really good
Very close,
example.
yeah.
Yeah, this is a really good example on the importance of engaging patients and making that research and the resources really meaningful. So, I hope this will be valuable to you. Let me switch slides. And me and Gail, we are going to be alternating and talking between slides. So just so you know. So this is the agenda for today's presentation. So we're going to be presenting in the beginning and then we're going to have the questions, answer your questions in the end. So we're going to provide some background information, why this project or this publication was necessary and the importance of engaging women with lived experience in the context of cardiac rehab, how the study was developed, the design, the co-creation framework, how we engage women in that process, about our participants, the results and insights, what we learned from engaging women to tailor those educational resources, and just some take-home messages. So just thanks so much, Sadia, for introducing me and Gail. I just wanted to highlight that we also had another member in our team who is now Dr. Ana Paula Bontempo. She was a PhD student. She already finished her PhD. She was a PhD student from Brazil that came to spend 1 year with me at U of T, and she's now back to Brazil. And she finished her studies, so she was a big part of that. So I want to say also thank for her contributions. Okay, Gail, up to you.
Where's, oh, there we go. So why women's heart disease? Or why women's heart health? Because heart disease is the number one killer of women worldwide, and it is the leading cause of premature death of women in Canada. In fact, there is one woman every 20 minutes that dies from a heart-related heart disease in Canada. And most women actually think, if you ask them, they say, what is the number one killer of women? And they would go breast cancer or
Mhm.
some sort of cancer. And that is untrue. It actually is heart disease. We know that women's hearts are different. Our hearts are not just smaller. We're not just small men, with smaller hearts. Our hearts are actually different, and they're affected by a whole lot of different things. Our risk factors are different. And because we have hormones, we have pregnancy, we have menopause, all of these things very much affect our hearts and our risk factors. Our symptoms, without a doubt, women symptoms are different. And most women have three symptoms in a row. And unlike the clutching, oh my gosh, my arm, my chest is tight, trouble breathing, boom, on the floor you go. Women can go for the longest time with a ton of symptoms and they don't even know what they are. They don't understand them. Typically, though, when they are into the hospital and once they start learning, there's usually three things. Women tend to get three things at once. They can have back pain, they can have jaw pain, they can have indigestion. And they're thinking these are all three different things. And these can all be that they're actually in the throes of having a heart attack. And they don't even recognize it, and physicians don't recognize it. Our heart disease our heart disease looks different, and it looks different because, again, we're not the classic Hollywood, and Heart disease, we get vasospasms. We have all sorts of little intricacies. We get the vasospasms, the small, tiny little arteries within the heart. That only actually has come to light in the last, I'm going to say less than 10, 5 years, even that vasospasms have only really started to become a word in the last couple of years. Nobody knew what it was. That, women used to have this X factor in their hearts where they were having what was like an angina, but their arteries are clear, and yet they're still having a ton of chest pain and debilitating chest pain. And that can just be that's microvascular that can be going on within their hearts. And that they're only starting to really recognize that in the last little while. We get treated differently. Uh, I mean, it doesn't even have to be hearts. You go to the doctor and you in your 50s, and suddenly it's all about menopause. Oh, you're depressed. Oh, you're anxious. Oh, it's hormones. Oh, it's lack of hormones. It's all of these different things. So when women are going, very often what they are reporting to their doctors is actually the very beginning of a lot of heart disease symptoms, and they've got risk factors, but we don't have the clinical doctors are just not as well educated. They're getting better, but you talk to a resident in a hospital, they get like 3 hours of study about women's hearts and what are their symptoms and what makes them different, whereas heart stuff gets a lot of a lot of it, and it's all based on men. Most of it is all based on men because men are easy. They're easy to study. They don't have hormones. Anyway, don't get me started on this. Okay. So we are, in a nutshell, we are understudied, underdiagnosed, and we are undertreated.
Thanks, Gail. So, what is cardiac rehab? So, remember the focus was of this paper was to develop educational resources for cardiac rehabs. So, cardiac rehab is a secondary prevention program that mitigates the burden of cardiovascular and heart disease. So, it's a class 1A recommendation. There is multiple studies, most in men, but there is real data on women showing the effects of cardiac rehab in reducing morbidity and mortality by 25%, increasing functional capacity, increasing quality of life, and so on. And cardiac rehab, it's a multidisciplinary, multiple components are involved, and those components are listed here. So we have medical evaluation and risk stratification. We have the exercise training. We have nutritional counseling, psychosocial support, patient education, and medication management. And patient education is key because we want those participants to understand what happened to them so they can really there's lots of studies showing that knowledge and awareness it's really associated with behavior change, with exercising more, eating better, being active, taking their medications properly. So patient education, it's an important core component of this effective intervention for the leading cause of death worldwide in women. And the benefits of cardiac rehab for women, they are well established. Um, we have done this, I think it was 3 years ago, this systematic review and meta-analysis to really establish the benefits of cardiac rehab for women. But I'm saying that because I think 10 years ago, when I was doing my PhD, we actually have a publication that was a systematic review and meta-analysis attempt. We tried to show the benefits of cardiac rehab for women, but there is not enough randomized controlled trials at that time. I think it was 2007, 2017 or something. But now we were able to establishing those benefits. They are in both physiological and psychological ways. So as you can see on the red physiological ways, cardiac rehab it showed to reduce so to promote risk factor modification, decrease hospitalizations, increase functional capacity, and so on. But also, very important specifically for women, the psychological piece, increase quality of life, the feelings, changing the feelings of social support, promoting social inclusion, self-efficacy is a big piece, decrease of anxiety and depression, and so on. So this is well established. So we know cardiac rehab, it's effective and it's effective for women. But when you go to any cardiac rehab program, and you will see that mostly, especially here in Canada, but worldwide, it's mostly attended by white men, highly educated, or men in general. And this is probably because of the historical pathway, or saying, or what Gayl mentioned, that women's hearts are different, the symptoms are different, they are underdiagnosed, undertreated. So women end up not even knowing they had a heart attack or they have a heart condition. So they and sometimes there is the doctors, there is a study showing that the doctors have lots of medical doctors, they have lots of assumptions, they do not refer women to cardiac rehab. But when we ask women why you're not participating in cardiac rehab, and these are women that were referred to cardiac rehab, and these are barriers worldwide, with a study with 2,000 women. So the results, or the barriers are, the main barriers are listed here. So women do not know about cardiac rehab. They're not referred, or they were referred, or it's one paper in the middle of lots of papers they receive at the discharge. And but sometimes the MDs are not even referring women or not encouraging them to attend, and that's a big thing. Of course, there is socioeconomic barriers, distance, transportation problems, cost. There is the physical part. The women find exercising tiring and painful. They feel that cardiac rehab it's only related to exercise. They don't understand there's other components involved, including psychosocial health or psychosocial support. And they also have other healthcare problems like osteoporosis, arthritis, urinary incontinence. They really make them not feel comfortable exercising in group. And then, of course, family responsibilities and caregiver responsibilities, which are big barriers for women to participate not only in cardiac rehab, but in adhering to exercise practices.
So, as a peer support leader for women, and I've been a peer support leader with the Canadian Women's Heart Health Center in a program called Women at Heart, and it's a 4-month program that we put women through for peer support after cardiac issues. And I've been doing this for almost 9 years now. And as a peer support leader, I hear so many women just even in these groups who are echoing the sentiments on this, because we do talk about and go into why cardiac rehab is so important. And anyone who hasn't gone through it by the time they reach our group, we highly encourage them, and many do reach out and get referred and go back into cardiac rehab. But I know that the women who seem to have the best experience at rehab are the women who find other women. Okay, so they're going to find someone that they can chat with and they want to share their experiences. It is surprising, actually, the number of women who say that they were the only woman or there was only a couple of other women that were in their rehab group. And a lot of women have said they didn't even finish their rehab because it just wasn't engaging enough for them to keep showing up. Women who had some other woman to chit chat with while they were doing their stuff and talk and share, they seem to be the women very often that were going through and completing their programs.
So, there's many factors that affect how women participate in cardiac rehab, but they want to see themselves in the education provided, and they really wanted to, as Gail said, to have someone to chat and have resources that really align with their needs. So, Cardiac College is a virtual institute, that's how we call it, but it's a website with evidence base. It's an evidence base, so there's multiple studies, including RCTs, that show that it's effective, and it's a kind of a place full of educational resources for men and women, for people attending cardiac rehab, for individuals attending cardiac rehab. And I think the great thing about Cardiac College is that the resources, the educational resources, are available in multiple languages. So I think there's 10 languages now in total, 8 or 10. I'm not, but and they are culturally adapted. So it's not just getting the resources and translating, right? So they're culturally adapted. And also, there's multiple formats because we know that people learn differently. So let's say the information about diet, you can have pamphlets, you can have videos, you have short quizzes. So there's multiple formats. So because people learn differently. But what we learned, and you can see here in the process, was that women needed different materials. They needed, their needs were different. So because of that, and because what we learned in the literature and the barriers that women face to attend cardiac rehab, we embark on this journey to develop what we call Cardiac College for Women, which is pretty much section of the Cardiac College with information that was based on women's needs. And this was the process that we followed. So we had the literature review to understand the information needs and preferences for women related to educational resources. Then we did a global survey and we asked programs, do you have any resources that are women focused? Do you feel your patients, your women patients, they need different resources, what they told you during the program? And we did this global survey, but also we did some focus groups with Canadian cardiac rehab programs. And then based on that information and our experience, and by our, I mean, there's patient partners, but also clinical team and researchers in the area and health educators. So we developed the Cardiac College for Women. And these are like what we did. It's the name, the content, format, page. We had patient and expert review, put in plain language, and of course bilingual because it was focused on Canada. And then after that, we assessed the impact, and we showed that the group of women that were receiving that Cardiac College for Women or the women focused education, they increased their knowledge, changed some of the behaviors, improved quality of life, and actually increased the cardiac rehab participation or the number of sessions that they participated more than the group that were receiving the education that was just a, which was great, but it was not specific to women's needs. And most importantly, we evaluated the implementation and acceptability of patients and program. If the healthcare providers delivering the content, if they thought that this could be something that could be ongoing in their program, as well as the patients were satisfied with the education provided. And these are the resources that were created. But as you can see here, so what we created was like pages on the website, slides for healthcare providers programs to use, some animated videos, and experts talking about some key points in short videos. It was a short video series. And then we had a three-part series with Gayl leading that those videos and really sharing her journey about like sharing her story and really what she learned and what made a difference. And this was by far the hit of all the materials that we developed. So we saw that, okay, this was something that really women attending cardiac rehab programs, they're very interested, which was like, I want to see myself in those stories. Animated videos were great. They were very expensive, but the simple video, which was Gayl talking about her experience and sharing, that was very powerful. So that was something that really sparkled me to continue to engage with her and refine some of those materials to really align to the needs of that specific population.
Oh, is this me?
It's you.
Okay, so this was, you know, for patient partners. This is, you know, what we learned from this first study that I was working with on Gabriella. We heard these women. They really want to hear, they want to go. It's just not about my heart. It's actually all of me. They had, a whole number of things that they really were very vocal and indicating what things were really important to them. In that storytelling, sharing, they wanted to make it personal. They wanted tools that they can actually use. They wanted to be able to learn on their own. Um, on their own time and on their own terms. They didn't want just visual. They didn't want just written. They want, I want. This is, they were, once you get these women going, let me tell you, they can be pretty darn vocal, but they were just really information hungry. They were just saying, just give me as much information as possible.
Yeah, you're right. And they want to hear the experiences again, similar to them, to mine. So that was a big thing. Yeah. I think that's yours too, Gail.
So, why engage women with lived experience? Well, I'm a little biased being one myself, but let me tell you, again, as a peer support leader, I can tell you that lived expertise matters. We all can sympathize with somebody in any condition that they have or their story that they're about to tell or they are telling you. But unless you've walked that path, you can't really empathize. You can't really go, I get it. I really get it. And I really understand where you're coming from. And that matters. That matters because when you have had some sort of a heart condition or you've had a heart attack and come as close to death as you want to think you're ever going to get, you're terrified and you're scared, and it really reaches you on a very deep level that you are looking for someone to say, I get it, I understand that fear, I understand where you are. So this expertise matters. Um, Relevance, we have our input. Again, it's all of this background and everything that we bring to create educational materials that can help women and to reflect their needs and experiences. Better engagement when somebody says, "Oh, there's somebody who's been there, done that." I want to hear from them because they truly do understand. And equity, you know, can't be enough said about having patient-centered, gender-responsive care across Canada. Yay, women, go women.
So, of course, based on everything that Gail said, we embark in this journey to engage women with lived experience to improve, refine, modify. We didn't know where we were going to end up in the beginning of the journey, but we wanted to engage those women to review those educational materials and make them more relevant and accessible. And these are the methods that we use. This was a mixed method study. We follow a principle, the guiding for reporting involvement of patients and the public, GRIP. We put together a patient advisory group. We didn't call participants. These were like women with lived experience, including women that attended and did not attend cardiac rehab. We used the Piper Toolkit and the IAP2 spectrum to guide that engagement. And then we had different levels of engagement. I'm going to share with you in the next slide, but it's inform, consult, involve, collaborate, and empower. We had different measures to assess engagement, and that was very important to us to make sure that those women, they were really engaged, but also just being able to share their perspectives and just not just listen, sorry. And then, of course, satisfaction in the end. And we compensated them for their expertise and their time, which is very precious. So this was the patient engagement process. So first we start with an information session with potential women that were interested. And then this was a live session, but we also have a recording version. And then we share with them what the process involved. And if they were interested, they could be part of that. And then we started with the workshops. We had 5 workshops, so 5 engagement sessions, and they were led by Gayl. So the discussions were followed. We have principles that we put together with this group of women about respect, inclusivity, and co-construction. Then after each workshop, we send them a short survey so we could get immediate feedback and really make sure that they felt that they were heard and engaged, and if there was any change that we need for the second or third or the fourth or the fifth workshop. And then we also had newsletters of key points, discussions. So they were always informed of what we are doing, me, Gayl, and Anna, and the next step. So we think that this worked very well, and they felt that they were part of the process, not just, oh, I'm coming to this workshop. And then, of course, in the end, there was the final survey that they completed, and we analyzed the data to really identify key messages and what those women wanted, what changes we could do with those resources. And this is just I kept this slide with the dates, so you know what how we structure those workshops during the first session, the information session. I was able to ask them about what period of time of the day would be good for them, and then but the dates were already set up. So that was a busy time because December 10 is close to Christmas, and those women were very busy organizing everything, but it worked very well. So we set up those dates prior, and that helped a lot for planning. So these are the participants. We had 36 women with interest in participating. 24 attended the information session, and 9 requested a session recording. And then there's a post-session survey to share availability, and 16 of them said they will be fine. They are available with those dates, but in the end, 11 women were invited to join the advisory panel, and we felt there was a good number because, of course, remember it's like a 90 minutes session, and we really want them to participate. So 11 women plus me, plus Gayl, plus Anna talking in 90 minutes, that was just,
If I can just say, when you get a whole bunch of women starting to feel like they can talk and speak their voice, it's like herding cats. So
yeah.
11 was fine.
And unfortunately, I'm going to say, as you can see on the right side of the slide, we were not able to attract the diversity that we were hoping. We got mainly Caucasian, highly educated women, but at the same time, we felt that was a big step because we don't see lots of studies like that. So I think that was a big step already, an important step. And then we hope to, in the next stages of this project, engage a more diverse group of women. And these are the engagement with workshops. This picture, it's part of the paper. I'm not going to go into a lot of details, but one important thing, and this is wrong, the workshop, it's not corrected. But anyways, I was just going to say that for me, it was very important to record the sessions and then see the percentage of those women were speaking. And you can see the first session, each session had a different objective. The first one was us presenting the educational materials. So of course, we would just speak more, but the consult, involve, and collaborate parts were them providing their feedback. So that was like the consult, they spoke more than half of the time, which was great. And then the empower, because they, in the collaborate session, they kind of provided lots of ideas for the empower. So the empower session was really us making sure that we got the message right of what they wanted. So that's why the difference in the spoken time, and the satisfaction was always high. Almost, this was a Likert type scale out of 5. So we were very excited with that. And as you can see, the attendance, just the first session, all 11 women attended, but they all completed all questionnaires, and we were sending the slides and more information to them. So they were still contributing through the surveys. Gayl?
So some of the challenges that we had, which is, pretty much would be about anything. We did definitely have a challenge in minority groups. That was a lot of, I think, it's just that whole socioeconomic issue that we have. And if you're talking of minority groups, then we start getting into a lot of immigrants And with their backgrounds, a lot of them are just not comfortable in doing anything like this. It's outside their comfort zone. And especially, we're looking to, and I know this just even in the peer leaders, looking to get more minority group leaders because, again, it's that you see yourself and that's your comfort zone. You want somebody that is more like you. So that was a bit of a challenge. Scheduling was definitely a challenge because this was, even though these women are retired, they have family obligations, they have personal obligations, they have doctor's appointments up the yin yang. There's just a ton of stuff. So the scheduling was interesting. Getting the questionnaires completed, that was a challenge, mostly because a lot of these women are not computer savvy. So, it would be a matter of following up to see, oh, I've lost the questionnaire. Can you send it again? They can't find it. So, that was minor, but it was definitely something. And some of the challenges was participation during workshops. I tend to be a chatterer anyway, but even trying to get them involved, sometimes the first ones were a little bit of a challenge, but I'm telling you, once you get going with some of these women, it certainly was the challenge was eliminated once they really felt safe, comfortable, and able to use their voice.
Yeah, it's true.
Hmm. So in the study, we actually find that there was five key messages that we received. Number one was the accessibility of resources, and it was really clear that our participants had found it hard to find online resources that they could relate to. Whether it was because there was not enough search engine coding on sites that were, for women, and the sites that they did find, they were saying that, it just wasn't women-centric information that they were looking for. And even if they did find them, it could be confusing for them in their age group with their computer knowledge. It was very confusing to navigate. They weren't sure where they were going, too many clicks, then they got lost, then they wanted to go back to where they came from, couldn't figure it out, got mad, shut the computer down. And that was the end of that. Storytelling, so powerful because as women, we were late with stories. We want to hear stories from other women, and then we contribute with our own stories. We've all been that group of women who were sitting around, and the conversations are just going back and forth as we share with others and we relate to what others are telling us. So, sharing empowers our own journeys in life. And this was a really, really strong message that the women gave us. Representativity. The women wanted to see themselves represented, their colors, their stages of life, and even different languages if possible. The more the better. They were really clear that not one size fits all. And multi-format. Again, not everyone wanted to receive their material in the same way. Not everybody wanted to see a video and see it visually. They didn't have time. They wanted to access something that was in writing so that they could just download it and read it at their own or use it as reference material. And again, very clear preferences on what worked for them. And then strategies to reach more women. This was a really fun part. I found this is when the women really got going. And they were really forthcoming on what could be done to reach more women and encourage them to engage in cardiac rehab. They wanted to see more information and posters about women's hearts. What makes hearts different? What are heart attack symptoms in women? Why aren't they in doctor's offices, health clinics? Why don't I have one in my church that I'm reading all the notices? What about community centers? Anywhere that people are standing around and there's things to be read. So from these discussions, the pièce de résistance came forth, and we decided to take that on and bring it to life. So the suggestion that really fired these women up was one where they could go to a site and they could see and read transcripts from other women about what they had gone through. They were looking for a place where they could see themselves in other women's stories and relate to what they had, and in some cases, were still going through. Somewhere they could relate to and not feel alone on their journey. And that was a recurring theme,
Uh-huh.
feeling alone. Like they just wanted to know that there were others out there that could understand them. So we made a website, Our Hearts, Our Stories, and we've started populating it with women's stories. So for some of the women that are now on the site, it was the first time they'd actually gone back and relived their experience. And for some of them, it was really hard. The discussions we had after the recordings or even before the recordings, for a lot of them who had never told their story in the way that we asked them to do it, it was not, I wouldn't say traumatizing, but they found it somewhat cleansing to have to go through and realize how far they had come for so many of them and how not scared they were now, given what had happened. So we consistently heard that they were really happy to have done it, to realize where they had come from and how far they had come. And I just, again, cannot emphasize enough how powerful storytelling is for women. And the number of views we're getting is quite surprising. You know, we're looking for more stories. And so if any of you have anybody who has ever had a heart issue, gone through a heart something, please, we'd be very happy to be able to have them contact us and get on and do their stories, especially anybody that's in a minority.
Mm.
And we're very surprised. Sorry, if you want to just go back there for a second.
Sure.
We're actually very surprised. I think this is an older number that we're looking at, but it's
Yeah.
been surprising now. We've been doing a bit of looking, and it is surprising the number of women that are finding us and the people that are coming and looking and the engagement. So they're obviously using the site. So we're very heartened by that.
Yeah, we launched the website, I think was February last year, so almost 1 year. This is the information from January to October.
Yeah.
Um, Very exciting. Thanks, Gail. So the take-home messages for you today is very short because I think we touched on all the points and we're excited to answer your questions. Patient engagement is essential. And thinking about me as a researcher, it was essential because, again, we developed the materials, we didn't include their stories, and then hearing from women, we took the next step and we created a new website. So it was very powerful for me and really eye-opening to see how important that engagement was to direct the research and the resources because it's a lot of effort. So we have to have the right person next to you to us. And patients are experts, so we need them in the table in those projects. The advisory panel approach was effective. I show you the engagement and women, like the ideas were great. As Gail said, they started and they were going, they were engaged. So I think it was very powerful to have them not as participants, but as part of the research project, really advising us on what to do. Accessibility must be a design priority, and this was the important part that was really mentioned over and over. But again, we need to hear from minority groups as well and other groups, disability and so on. So storytelling, it's a big thing. As Gail said, I'm not gonna even add anything. It's so powerful. Representation matters. They want to see themselves. And it's not just about the diagnosis. It's not just about my how my heart works. It's about the language. It's about the ethnicity. It's about age groups. It's about socioeconomic situations. So it's very important. And continuous feedback improves outcomes. So it's not just, okay, I developed this materials, it's great, people are satisfied. When we develop educational resources, we have to have ongoing feedback and a process to update those resources. And I didn't have a chance to move forward, see how those stories and watching those stories really make an effect on some outcomes. But this is for the next step of the research. So stay tuned for that. And just a short, the final outputs. Again, we are sharing with you the manuscript, but we presented those as an abstract in the Canadian Women's Heart Health Summit. We also did a presentation, like a podium presentation me and Gayl. And then last year in Madrid, I was actually able to also present a poster there and really get a lot of feedback because um, it's still engaging patients overall or people with live experience in research is not something that it's common there. So I think I engage in lots of great discussions in the European Society of Cardiology conference. And we want to thank you, all the women with lived experience that were part of the advisory panel and approved us to include their names. We also want to thank Piper, the Pride in Patient Engagement in Research, who is an initiative by University Health Network, who funded this project. I want to also thank Gayl for her passion and engagement and leadership and engaging those or providing leading those women. I think it was really great for me to see, and I really appreciate your time and your expertise. And thanks for the opportunity to talk about our project.